Good morning.
Good morning. You're still a little bit frozen.
Oh, really?
Yeah. No, you're not. Look at that smile. To brighten everyone's day, right? Okay, so I have a bit of an eye infection and I apologize. So I look kind of not great, but please forgive. We have questions
All right.
and really good ones too. And guess what? Somebody really excellent to answer them. So I'm going to answer them. No, I'm just kidding. Okay, can we get started?
Sure.
Okie dokie, my dear Dr. R. I'm all jerry-rigged here because Daryl is using his laptop to record a something. Okie dokie. Number one question, Dr. Rosensweet. My Dutch test showed very low testosterone, and I have no libido. So I started to use meaning testosterone, as all of my sex hormones are low, and I am very symptomatic. Can Dr. R please explain how it is total testosterone would be high, yet free testosterone is within the reference range while taking low dose topical BHRT testosterone? I'm thinking that means there's too much overall testosterone, even though I am not symptomatic for elevated testosterone. Quite a question.
Yeah. There's this is remedied from my perspective by being able to be in an actual consultation with an actual patient and being able to learn a lot more. There's some information that she's providing, but there's a lot more information that I would need to be able to sort this out. And I so encourage folks to become patients of someone who really knows what they're doing. And, I know there's a lot of testing methods out there. And the particular testing method that was mentioned, from all that I have learned, this was not a testing method that I can help her with.
Right.
Because it's not a testing method that I've come to be able to believe in and trust. And I'm not trying to injure anyone's business, but we've done some looking into it, and from my perspective, I cannot rely on this to provide the kind of data I need. And one of the things that's missing is this woman in the menopause or in the perimenopause? And maybe if she's in the chat right now, it would be helpful for her to tell me how old she is, how much she weighs, how tall she is, how many times she's been pregnant, and when her last period is. that information happens to pop up, I could help her a little more. When she's talking about free testosterone and total testosterone in a low dose, I've heard the word low dose before, but when you've got an elevated testosterone, it's hard to know that it was a low dose. But part of the problem, I think what she's reporting is blood tests when you're talking total testosterone and free testosterone, because all the urine testing we're measuring free testosterone only. We're not measuring total testosterone. So I'm thinking she's referring also to a blood test. And it all depends on when you took your last dose. So when you're talking total testosterone and free testosterone, when did they draw your blood? in relationship to when you took your last dose. If you took it 2 hours ago or an hour ago, we can't. This is why blood test doesn't work. It's so dependent, usually, upon when they took the last dose. I know a lot of providers are using blood tests, especially in males, to evaluate hormone levels, and there can be some value, but a ritual needs to be established. Like the individual provider has to define when the patient is to have taken their last dose and when they're to have their blood drawn. Sometimes that's 12 hours later, like they took their nighttime dose and they got a morning blood draw. Sometimes it's 2 hours later after they took their morning dose. But individual provider has got to be very familiar with those kind of issues because, again, blood tests relate primarily to when you took your last dose. Now, I'm not an expert in blood tests, so I don't want to go further. And I know some of my esteemed colleagues are using blood tests, especially for males. So if anyone has been confused about my answer to this question, you ought to be. Yes, I've sort of wandered all over the place. When a woman's having trouble in menopause, I like to start at ground zero.
Right.
And the way we do that is we enter official patient-doctor or patient-nurse practitioner relationship. They fill out a very, very, very extensive questionnaire. Oh my, very extensive, especially related to the female. And from just the reading of that questionnaire, I can get a lot of information about what I would expect the hormone situation was. And that's where I'd like to start. Testing a woman in perimenopause or menopause, that's a challenging thing. You got to really know what you're doing there.
Mm-hmm.
And and your timing has got to be correct. So I'm so sorry. The best answer I could give you is find someone who really knows what they're doing and start from ground zero. And so really, you've asked a technically a complex question and you've gotten no valuable answer whatsoever from Dr. Rosenzweig. Now, at the same time, this is a common situation where a woman has ideas or a provider has ideas and you embark upon hormone discovery, dosage discovery, balance discovery, pathway, and you don't necessarily get it. You don't necessarily get the wonderful relief and excellent results you'd hope right out of the gate.
Oh, yeah, right.
But do not be discouraged. I can't tell you how many women, because of individual differences and individual balance differences and all kinds of other moving parts, don't necessarily get it right out of the gate. Your best chance of getting it right out of the gate is you link up with someone who really knows what they're doing. And even in that instance, including the physicians and nurse practitioners that we mentor, sometimes it's a process. So you come up with your best idea, you implement it, you see if it works. But I just don't want you to be discouraged. There are so many women out there who have tried so many different methods. They haven't nailed it. Sometimes you get really discouraged. Do not despair. There's hardly a case in 25 years. There's only one that I didn't solve, and I wish the woman had given me more time. So think about that. One situation, 25 years, couldn't solve. Because sooner or later, if you keep following the bouncing ball, you know how to turn on your metaphorical microscope and zero in on the individual woman. You always can come up with the next idea and the next thing to try, and then you see how that played out. And eventually, there's only we can dial you in. You'll get there. So even though you're a little bit baffled right now, especially around libido and testosterone and the testing results that you have, don't despair.
This woman is very bright. She is an MP. She's in Hawaii. She's an amazing, amazing woman and has an incredible amount of knowledge. And I kind of have a feeling maybe she's treating herself. I'm not sure. So I really appreciate, yeah. Yeah.
But that
Yeah.
wouldn't be the issue. There's more to learn
Right.
with just from the amount of information that came in and that question. Who's ever treating her? There shouldn't be this much mystery at this point. And so start at ground zero and connect with us, mysterious woman.
Oh, I will let
Nurse
you know about
practitioner.
Mysterious Woman.
All right.
Definitely. So, thank you for that, Dr. Rosensweet. For the
For that
next,
non-answer.
huh?
For
For your
that
non-answer?
my non-answer.
Love your non-answer. I thought it was fabulous.
Yeah.
I'm going to write it down.
If you
And Mr.
possibly
Bijou
can.
loved it. He said,
Oh,
that
oh,
rock.
oh,
He's
that's
like,
why
hi
Bijou was
there.
there.
Yeah. Well, he wants to know about testosterone too, because he's a male
Yeah,
with a
yeah.
meow that's like higher than high. Guess why? Anyway, this second question comes in. For the 24-hour urine test, do I go off of all hormones before the test, including the E3 vaginal cream I'm using? I'm not sure, but my belief is that she's probably taking Premarin.
It could be E3 vaginal cream, definitely.
Mhm.
It
So,
definitely could be estriol vaginal cream, absolutely.
yeah, it
Probably.
could. It could. Good morning, Kathy, and good morning, Liza and Kara. Good morning. Good morning. We see you. So does she go off of all of her hormones before the 24-hour urine, including that vaginal cream?
This also is an excellent question. One of the phenomenal advantages of the 24-hour urine hormone test is we get a real-time reading of how much hormone is making it into the woman's body.
Right.
So, au contraire to what she is saying, we absolutely, it's an imperative for the woman to continue taking her hormones exactly like she always does. In fact, we stipulate that we want a woman, prior to doing the 24-hour urine hormone test, to be on her hormones without missing a beat, without missing a dose or something, for at least 5 days, 7 preferably. So once you got into that steady, oh yeah, I'm in a routine, I'm not missing any doses, then you absolutely continue that wonderful ritual you got going right on through the 24-hour urine hormone collection. That allows us to see precisely what you've got going on in your body. And if you were to omit, we wouldn't know what was going on in your body.
Well,
If
yeah.
you were to omit taking the hormones, oops, we wouldn't find out anything about what your hormone levels are while you're taking the hormones. We want to know your hormone levels while you're taking the hormones. Keep on taking them. Now,
Yes,
one
that
other
makes
caveat
sense.
there:
Yeah.
vaginal estriol. We understand why you would take vaginal estriol. It can be a real jumpstart to the health, to the healing of the vagina that's undergone vaginal atrophy. But the vagina retains that vaginal estriol, and you remember the female anatomy is the urethra, the tube that empties the bladder, empties into the vagina. And so when there's vaginal anything, we're going to get skewed urinary test results. And in fact, you have to omit them. You have to omit that vaginal estriol for, geez, we don't really know the exact amount. We had one patient omit the vaginal estriol for 60 hours.
Whoa.
It's over 2 days, 2.5 days, so that she wouldn't contaminate the urine specimen by peeing into her vagina, which had estriol in it. So she
Right.
omitted it for 60 hours. Very, very high estriol levels showed up in the urine. We knew it was contamination. So
Right.
we suggest a week or two of omitting the vaginal anything. Now, vaginal application of hormones, they can work well because the vagina is an excellent absorptive surface, but because we rely so significantly on the 24-hour urine hormone test, we choose other sites of application. and that's a whole subject unto itself. But here's the moral. Here's the answer to your question. Take your hormones for 7 days, preferable 5 days at least, religiously. Don't miss a beat, and keep on taking them right on through the urine collection period, except omit that vaginal estriol for at least a week.
Got it.
That's really important.
Yeah, well, it makes sense. It absolutely makes sense. Thank you for that, and I think that's going to be very helpful for her.
There's an interesting question that's come in. Before we lose it, I wonder if I could interrupt to
please
answer that question.
Sure.
It's from Kara. Hi, could menopause cause my GERD acid reflux to become much worse? Well, let me take a common situation. And my question is, Kara, are you taking hormones? And has your GERD become worse during the period that you've been taking hormones, and especially progesterone? Because progesterone is the great relaxor.
Mm-hmm.
And we need a lot of relaxation in pregnancy, but there's some downsides to it. Like, yes, it relaxes that pelvis and it relaxes the ligaments. That's fantastic. It really is helpful to delivering a baby through a pelvis. It's a fantastic thing. But it also relaxes the ligaments that hold up the spine. So women who are pregnant often get backache, and they're not getting as much support. And not to mention the gravitational challenges of carrying some 8 pounds or 20 pounds in front of your body. But women who are pregnant very often will get acid reflux. They've never had it before because the sphincter that closes off the stomach from the tube that feeds it, the esophagus, it's called the lower esophageal sphincter. It's got a muscle that makes that sphincter work. That muscle tightens to prevent acid from the stomach shooting up into the esophagus and thus burning the esophagus. There's a muscle that controls that. Well, that thing relaxes too. So sometimes, not always, women who go into menopause and are properly treated with progesterone get excessive relaxation of that lower esophageal sphincter from the progesterone. So there are some things that really matter. We highly recommend that you take progesterone prior to sleep time. It can facilitate your sleep.
Yes.
And we highly recommend that you eat a lot earlier than you are used to. Most adults have to eat. Most elderly adults have to eat a lot earlier than they used to. Like I could eat a hamburger when I was in medical school at 10 o'clock at night, and no problem. But I wouldn't dream. I really like to eat around 6 o'clock at night, and I can eat at 7. Why? Because we want the stomach to do its thing, number one, while we're upright, rather than laying down. Because how many adults have issues of GERD totally independent of progesterone?
Yes.
I do.
Yes.
I don't like to eat late, and I like to give my stomach a lot of time and a lot of help from gravity. So I like to eat early. So if you're having this trouble, eat early and take your progesterone late. Now, ordinarily, menopause itself does not cause GERD. It's only the progesterone treatment. However, GERD, or acid reflux, is very common at midlife. So there's a lot of things that relate to GERD, and what I'd recommend is you might start by going to iwonderdoctor.com.
My favorite place on the planet, other than here.
iwonderdoctor.com, because we have a lot of videos relating to the intestinal tract and GERD. What a funny acronym, eh?
It is, yeah. I say it all the time.
Intestinal reflux disorder, disease. Yeah. So caution, you might have to do many things to address the GERD.
It's interesting because she says that she's only taking estradiol.
That is interesting. So I'd say it's a coincidental thing. and go to I Wonder Doctor to address the issues of gastrointestinal reflux, because it's a very common thing. It's a real pleasure to gain in birthdays, to grow older. It's been one of the most wonderful things that's happened, mainly because of what I've learned and how I've grown, because of what I'm committed to. But there are a few downsides. A lot of them related to the physical body, and GERD is one of those common ones.
Ooh-wee. Yeah, and it's very, very uncomfortable, I must say. We don't like it. I'm kind of going off my plan here because there are a couple of questions that are just, sorry, they're getting me. This woman says, and it's Charlotte or Charlotte. Hi there. She says, how about surgical menopause? Me. I had a complete hysterectomy in 2019, 46 years old now. Do you feel that I should take hormones? And she says, also, good morning.
Good morning.
Definitely.
And here's my answer. Well, actually, I like to call it my passionate answer.
Can I answer it for you?
Go right ahead, Caroline.
Yes!
These hormones are so important. They're very, very powerful. And when you have surgical menopause, that means your ovaries have been removed, and you are now missing some extremely important hormones.
Like overnight.
Estradiol, progesterone, testosterone, DHEA, and you want these for the rest of your life. What we suggest to a woman who's going in for a surgical hysterectomy, that she set up with someone who's expert in treating women in menopause with hormones, and she get all her hormones, and she walk into that surgery, into that hospital room with her hormones. Here's an example of 4 hormones that you can take in 3 bottles, and you already have got your ritual that you're all prepared to do. And when you wake up from that surgery, you put those hormones on right away, and you do so for the rest of your life.
You bet.
So they're fantastic. They're important. And you know, you're fine. You're 46, and you know, starting them now is going to be just fine. Even though that surgery was in January 2019, you're catching it nice and early. And yeah, get thee to an expert and get going. Is my best.
Oh.
I'm just backing up Carolyn's answer to that question.
Well, I went through it, yeah, long backstory, but nevertheless, I will say 100,000 times 10 exponentially zillion gazillion million times. Yes, please do yourself a favor and replace those vital hormones lost, because life without them is not much fun. That I can totally guarantee you. And we need them for a multitude of reasons, which you and I have discussed over and over. Bones, heart health, muscles, you know, all the things that we talk about, and probably will still today. So this woman, bless her, says, I am 65 and have never taken hormones of any kind. My recent research is now telling me that I should have been, for heart, brain, and bone health, etc., etc. But I'm hearing, I have missed the window of opportunity, which is that 10-year window. Could you maybe steer me to some resources that could shed some light on that? I've got your book, so maybe it is talked of in there, and I thank you kindly. Aw.
Well, I say never say never, and I started treating my mother and my mother-in-law when they were in their 80s to benefit, significant benefit. And yes, it's ideal to start treatment of hormone replenishing when you're in the perimenopause. However, a lot of good a lot of great good can be done whenever you decide that you want to do it. So no fear. That book should be a really good outline of where you should end up. And then you want to find someone who really knows how to implement that in an expert fashion. And there is a caveat with your particular situation because you are over 10 years out. There is a situation where estrogen protects arteries. Estrogen does a zillion things, and it protects arteries. And for example, occasionally, rarely, a physician will hear of a young man, or a person will hear of a young man who had a heart attack in his early 40s.
Right.
Never sick a day in his life.
Right.
Don't hear that about young women.
Not often, no.
Because they have that special protection that estrogen confers to arteries, including the coronary artery. Turns out that the incidence of coronary artery disease is much lower in young women than it is in young men. However, that incidence equalizes in women and men by the age of 60. So there is a situation where, I'm not saying you have it, but that you could have possibly developed some coronary artery disease. And there's a rare situation where you actually have formed a clot in one of those coronary arteries. I say rare. I'm not here to scare you, but I tell you, when you're involved in a method of treating women in menopause that is extremely rigorous, as ours is, we pay attention to this kind of details. So in a woman who hasn't seen hormones for 10 years since her last period, quite often after taking our initial medical history and doing some testing, some blood testing, we will ask that woman to get something called a stress echocardiogram, in which the cardiogrammer, a physician hopefully, or techs they can be very good at this. They're able to put you under stress like a treadmill, and at the same time watch how your heart is with an ultrasound, how your heart's behaving. And someone who's got a partially blocked coronary artery, you're going to see problems. I heard a comment from a cardiologist saying that if he's looking at that stress echocardiogram while the woman's on the treadmill, and that heart is really put under the stress of the treadmill, he can tell whether there's compromise to the circulation to the heart itself. When that's the case, we want that treated first by a cardiologist. And they have a lot of tools, including stents, they can go right into that coronary artery and yank out a clot and put a stent in there. And then we want to make sure that your coagulation profile doesn't put you in the realm of hypercoagulability. So there's some things to do. Now, having said that, this whole exposure of this particular rare issue for a woman who's in their 60s, hasn't seen hormones for maybe 10, 15 years, this wasn't known, or wasn't popularly known among even experts like myself until a couple of years ago.
Right.
And I was having a conversation with a dear friend and colleague of mine, a prescribing compounding pharmacist named Jim Hernser. Oh, by the way.
By the way,
on Thursday, I'm going to be interviewing
sir.
Jim Hernser. We'll be having a conversation. He's really worth listening to.
I'm going to put that out on blast. Oh, you bet. I'm excited. Yes.
The man has had a tremendous amount of experience.
And he chimes in. He does from time to time.
It's an absolute delight.
Can't wait.
He and I were having a conversation, and, we've been treating for decades women in menopause. And he was saying, God, when I stop and think of all the women that I've treated of all ages, including those who are at very high risk for coronary artery disease, thus because they were significantly overweight or they had diabetes. Oh yeah, diabetes puts the arteries at risk. He says, when I think of all of the women that I have treated, I didn't even know about the window of opportunity, nor did I, until recently, in the last couple of years. None of them got into any kind of trouble whatsoever. So we're very thorough. We're not trying to drive you nuts with or try and frighten you. But sometimes after reading your very extensive history that we would take on you, and maybe even doing some blood tests to get a little sense of, are you at risk for coronary artery stuff? We may ask you, or may not, we may ask you to get an echocardiogram prior to beginning hormone treatment. And if that echo shows some issues, we may want to evaluate via a blood test your propensity to coagulate. Because
prior to my starting my hormones through menopause method, I was asked to go and see a good cardiologist. I had been 17 years out. That 10-year window was like, I was an adolescent. You know what I mean? I was like way out of that 10-year window. And it did scare me because I was like, really? But anyway, thank you, God, I was okay. And I was able to proceed. It's always a good idea, don't you think, to like rule stuff out?
Well, it depends. I mean, this is part of any rigorous process. Is we take a very thorough medical history. We get clues. From that medical history, we start to think, gee, this patient looks like they might have this risk for thus and so. Why don't we do a little pre-testing? Because we can get more clues. Or a lot of times we'll go through that medical history and go, no, this is a clear sale. Let's go right into treatment. So there's a medical process that is time-honored. Physicians and nurse practitioners have been doing it forever. You learn about your patient. And when you learn a lot about your patient, you get clues about how to proceed. Duh. That's how we do it.
Yeah, yeah. And even when people are talking, they will give clues. It's very interesting, really. To me, it is. And
let me say one more thing.
Sure.
I didn't know about the window of opportunity when I started treating my mother-in-law, who had 3 coronary bypass operations.
Now, she had not been on hormones ever, right?
Hormones ever. She had a hysterectomy when she was very young, in her mid-30s.
I don't know how she did it.
Had 3 coronary bypass operations because of severe coronary atherosclerosis. I didn't know about the window of opportunity. We started her on hormones, and it made a major difference for her for a couple of years.
And how old was she?
She did not get a heart attack from what we did. Pardon?
Right. How old was she?
86 when I started her. So, didn't solve all of her medical problems, and bless her heart, she's passed away.
But your mother too, and I know that backstory. She wasn't going to have her son treat her, and I get it. Although my dad treated all of us, but he was a psychoanalyst.
You want to reveal that on live TV?
Why not? It's all fine. God bless my daddy. He didn't really treat all of us. I'm teasing. Certainly not me, as you can well see. But that window of opportunity thing, when some of us women hear that, it really scares us. Like we are just,
I call it the medical curse. It's a different era of medicine. When I grew up in, I was telling someone the other day that when I went out into general practice in 1970, there was very little, quote, health insurance. Very few people had health insurance. There was very, very, very few doctors had malpractice insurance. There wasn't this big thing about malpractice.
No, and it was like one doctor per office, was it?
Yeah. And so these were very different times, and doctor-patient relationships, at least for a lot of physicians, were treasured, sacred relationships. And then I watched over the period of time that things started happening, like health insurance companies came in, or really medical insurance companies came in, and attorneys started entering the process, and some doctors got a little weird. And, so there's this tendency in medicine that I've been discussing recently, especially with a physician who grew up in the era, that if you don't warn a patient about every single thing, and you don't record that in the chart, that should that patient develop that thing, and you're sitting in front of a medical board or a court because you're being sued, you didn't have it in the chart. I forgot to warn you about lupus erythematosus, that you could, or whatever.
Right. Just a small little word.
So there's doctors that started practicing something called defensive medicine.
Oh, don't I know?
And so they started warning patients to protect their own hide. I understand it. It's not easy to be out there in medicine. It's a funny choice of a career.
It is now.
Not in my day, but not my day. My day is still happening royally.
Totally still happening. And to my father, oh my God, he loved what he did, and he was good at it. He worked at home right outside the kitchen. There was Dad, and he just wouldn't. No way. No, he wasn't. But I've seen that
So
change.
it's called the medical curse. And there are so many
curse.
patients that have been frightened by so many things. And so I know I've taken a massive diversion here, but if you connect up with someone who knows what they're doing and is really specialized in treating women in menopause, you will find appropriate path, and you will not have to be frightened, and you will not have to be scared. You just figure out what's best for you, and you do that. And so I'm sorry to make this diversion, but you mentioned the word fear and being frightened by medicine and by doctors. And, it's a sad thing, but it can be remedied. Just find someone who knows what they're doing and really specialize in the field.
It's called the doctor shopping that we talk about so often.
That's your job. All you out there in Facebook land, your job is this. Find someone who is specializing in treating women in menopause that you like and you trust. That's your job.
Yes,
you'll be an active participant. Someone who really knows what they're doing is going to have you be an active participant in the process. The hormones are going into your body. That's why I wrote that book initially.
And you know what? The book is called Happy, Healthy Hormones, and anyone is free to download it free when, they're on the group, The Ins and Outs of Menopause with David Rosensweet, MD. Please feel free to download it. It's a great book, and you will learn a lot.
You'll be a partner in the process. That's the way it's best done. The hormones are going into your body. So it is a wonderful partnership, but ultimately you need someone who's a prescriber, and ultimately you really want someone who really knows what they're doing. Now, even having said that, for decades and decades and decades, women have been on hormones, even Premarin and Prempro. It's been a great benefit to them. Non-expertise can also be beneficial, so I don't want to discourage you. There's a lot of women out there, millions of women, who got a single pill of Premarin or Prempro, did really well. So I'm not an advocate of this, but hey, listen, women, here's job number 1A is when you go into menopause, get hormones. That's job number 1. You want to replenish these hormones. You want to replenish all of them, not just estrogens, not just progesterone, testosterone and DHEA too. They really, really matter.
Sad thing, and I'm sad to bring up something sad, but sad thing, and many doctors go into the art of medicine to treat patients to help, but will say no when you ask for hormones. And
We're
so
working off of old information.
I know.
In 2002, as so many of you out there know, there was a medical study called the Women's Health Initiative, one of the most expensive and extensive studies of all time. It was evaluating Premarin and Prempro, and it falsely reported increased risk of breast cancer in women who were taking Prempro.
And it was a wrap.
In that original study in 2002, it says in the fine print that the increased incidence was statistically not significant. Oh my God. In medicine, that means, in science, that means there is no increased risk.
Right, it's moot.
Statistically insignificant.
Right.
And but the press went ballistic with this, and it scared women all over the planet, and scared them. 18 million women were on hormones at the time. 40% of the women in America who were in menopause were on hormones. 18 million, and that number plummeted down to the low millions. Scared that many people, and it scared doctors. And even though by 2006, the relative risk had actually gone to 0 extra risk, technically it's 1, the relative risk was 1. And in 2017, the exact same study committee that produced the original Women's Health Initiative published in the original journal that they published in, JAMA, Journal of American Medical Association, that after 18 years of follow-up, there's no increased risk of breast cancer, heart attack, and stroke. How many people have heard of that? How many physicians and nurse practitioners have heard of that? Sooner or later, it's going to leak out. More and more, I can tell that the streets are learning that that was a mistake. It was an error. What a calamitous error.
It was huge, and forever.
Things like that happen. I just don't understand them. Misogynistic type events one could editorialize. But at any rate, you're not at increased risk for taking hormones. You're at less risk if you take hormones than if you're not treated with hormones. We're all at risk. We're all at risk for all kinds of diagnoses, thousands of them. We're all at risk for cancer.
Crazy.
I'm a man. I'm at increased risk for prostate cancer. Many of you heard me say this many times. There's reasons why I'm at increased risk for prostate cancer. I'm not going into those right now. Women are at increased risk for breast cancer. There's reasons why that's so. However, in general, with all of us at risk for cancer, women who are treated with hormones are at less risk for breast cancer than women who go untreated.
Can you say that one more time?
Yes. Women who are treated with hormones in menopause are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones. That's the science. It's pointed out in a book called Estrogen Matters. For those of you who really want the details, Estrogen Matters by Alvin Blooming and Carol Tavris. And there is the science right there. So
there we go. I have another question.
We took a little trip down risk and Women's Health Initiative lane once again.
Yes, and that is A-OK today. A question came up saying, can you have an autoimmune condition and take bioidentical hormones?
Well, theoretically, they're not related.
Right.
But what I would recommend for someone with an autoimmune condition, take the hormones. For example, a very significant autoimmune illness called multiple sclerosis. The immune system attacks the nervous system.
Right.
One of the things that's been well known for as long as I've been in practice is that women who are pregnant and have MS often go into remission. That means it quiets way down. Oh, well, the hormone levels in in pregnancy are just astronomically higher than
Yeah.
in a young woman. So there's medical research papers that suggest a treatment for MS in women is to give them one of the hormones, estriol. It's an estrogen, as treatment for MS. Now, it's not going to work in every case. Autoimmune illness has got a lot of moving parts. You want to try and get at the causes of why the immune system would attack your nervous system. So, au contraire, to me, getting your hormones balanced, the hormones being present or not present are not the cause of your autoimmune illness. They're not the cause.
Right.
However, balancing the hormones, because these biochemicals are so strong and so related to your health in every regard, balancing and replenishing them to optimal levels, absolutely do that in cases of any diagnosis you can name.
Mm-hmm.
Now, there's other moving parts. Why did the immune system get triggered to attack one of your, like your thyroid or autoimmune thyroiditis, or your joints, like an autoimmune arthritis? Well, there's a reason why it's provoked. And anyone who really knows how to follow that bouncing ball, such as a functional medicine physician or a holistic physician, many do.
Mm-hmm.
Many of us have had special training in this. You want to look at the gut. You want to see what's provoking that immune system. Is partially digested food leaking through that gut and provoking that immune system to be hyper reactive because it's got to handle much more than it's used to handling. So get thee to, if you have autoimmune illness, take it on, because all these illnesses have causes, and they all have, there's a biology related to every one of them. And follow that bouncing ball. There's a lot of books written on it. There's a lot of physicians and nurse practitioners and healthcare providers that are very schooled in how to track down what in the heck is provoking your immune system to attack whatever it's attacking. But get the hormones right.
For sure.
Regardless.
Yeah, regardless.
They didn't cause your autoimmune illness. And yet having low hormones or unbalanced hormones is a stress to your body of a very significant order. So,
it's not going to help okay, I get it.
From what I've heard, none of us need additional stress.
I have some in the closet, but I'm not letting it out because, I don't really.
You don't want to look in that closet.
Actually, there's a mirror behind me. You can look at my
don't open that door, please.
No. It's the big monster that's going to come out. Are you kidding? Forget it. Stress can stay back there. We worked very hard on being non-stress, and it feels so much better. It really does. So, yeah, I agree with the hormone thing, because...
Just a little side track on the stress. The stress isn't the problem. Part of life on Earth, stress has got a special function.
Mm-hmm.
It's not the stress. It's how skilled are we at healing the internal stress that tends to come up in the surface in this lifetime. What's our skill set with our own emotions and our own mind?
Yes.
And, so that really does matter. And I suspect a lot of our audience have been down, care about personal growth and care about personal healing, which always brings in the emotions and the mind and the life.
Yeah, it's healing, and it's a journey worth taking for sure. Doing the work. It's not easy sometimes, but sometimes we have to allow ourselves to, I guess, how does it go? Be comfortable to allow ourselves to be uncomfortable, or vice versa.
That's a good skill.
Yeah.
We don't care about your closet. You can open the door.
Yeah. In fact, the stress went out the other way while we weren't looking. So we are at that bewitching hour. We have
my God, look at that.
It's the craziest thing. So I will get to more of these questions. Thank you, God, Liza and Emma and Lynn and Sal and Antoinette and Charlotte. I think it's Charlotte. I speak French. I apologize if I'm saying it incorrectly. Krishna, everybody who's come up now. Plug Dr. Jim. I believe he's Dr. Jim.
No, he's a pharmacist, compounding pharmacist.
Well, he's special, whatever he is. And he is going to be your guest here on the 29th, I believe. Yeah?
This Thursday.
This Thursday. My dates are all off, please do know. But, oh my God, I'm so excited about that. I really can't wait. And he does chime in on the ins and outs of menopause here and there. And I think it's going to be wonderful. And so with today being Tuesday, I think, I will speak with you a week from. And today, a week from today. That's 7 days from now. I got the math down finally. But I want to wish everybody just an amazing, amazing, amazing week and weekend. And as always, thank you so much, Dr. Rosensweet, for your amazing answers. I see many of the posts that come up because I do. And they're just great. And I truly do believe a paradigm shift is happening. It is. We're working hard on it in menopause land. Right?
Right.
In a good way? Anything else to say?
Nope.
You seem speechless.
I'm sending you the remaining of the screenshots of the questions. And
thank you.
Until a week from today, everybody, or we'll see some of you on Thursday.
Indeed. Oh, I'll be up for sure. Are questions going to be allowed?
Yes, for sure. Absolutely.
Very cool. Okay. Well, you know what? As always, peace and blessings to everybody. To you too, dear Dr. R. Thank you for today. Good to see you.
Thank you, Carolyn. Thank you, everybody.
Indeed. And of course, so we'll see you a week from today. And Jim Hernser will be here on Thursday with Dr. R.
That's right.
Enjoy.
Bye-bye.